Thanks for having me. I just want to start off. My name is Betsy Shalley Jensen, and I just want to let you know that all these people were cued into what we were going to do up here this morning. Just kidding. But I was just told that I'm going to be talking about a systems perspective.
Well, no, I said that's something that might fit for you, but I'd
No,
ask
I'm
you
happy to do that.
respond from your heart and to
From
our
my heart.
presenter.
I'm happy to do that. Betsy Shalley Jensen, I'm currently director of A Positive Place in Hampshire County in Northampton. Some of you might know us as AIDS Care Hampshire County. How many of you recognize that name more than A Positive Place? Some of us. We recently changed our name because of the folks who use our services were put off by walking through our doors with a sign that said AIDS Care, because stigma and discrimination is so strong against people who are living with HIV and AIDS that they didn't want to come and walk through the door that said AIDS because people would know that's where they were going. I want to talk about A Positive Place as a system that certain people come and use, and I'm going to be talking about systems because you gave me that task at a number of levels. A Positive Place now is over 20 years old. As you know, we serve people living with HIV and AIDS. What does it mean to serve people who are living with HIV and AIDS? We tried to create a system so that people could live fruitful, healthy lives with at once a fatal disease, now something called more like a chronic disease. We do medical, I'll use the words that everybody knows. We do medical case management, social case management, advocacy. We have peer advocates who provide counsel and support for other people who are HIV positive, and we have a housing support program, we have a benefits program. We created a whole system of support of total care for the population of people who use our services. Who are the people who use our services? Who are the people currently living with HIV and AIDS, people who are at most risk of getting HIV and AIDS? Men who have sex with men, gay men, African Americans, Latinos, transgender. People who have been historically marginalized from all of the systems that we talk about here today are people who are impacted by HIV and AIDS. We serve 65% of our population are men who have sex with men. It doesn't mean they're all gay. It means they're men who have sex with men. Even though 2.5% of the population in Hampshire County, or 2.6, is African American, 15% of the population who use our services are African American, 25% are Latino, and we have 6 or 7% transgender population. So what we notice is that we have a disproportionate number of historically marginalized people using our services. What a surprise. For our funders, we gather data, as Claire was talking about. How many of you are in some, community-based agency or something like that with a similar name, where you collect the number of times you did a visit, a phone call with a client, how many times you had a positive prevention conversation with a client, something like that? Okay, so we've all done that. So we were doing that in our little system. But then I was noticing, and the staff is noticing, the disproportionate numbers of historically marginalized people who are coming through our doors. What does any of this data mean? I had 6 conversations face-to-face versus 12 on the phone with this person. So we started to collect our own data. Long story short, we started to pay attention to data and use it, what people might now say, meaningfully. So we started to take a look at what health outcome could we actually start to track. In HIV, a health outcome that you would track to show or demonstrate that you were healthier than you had been is your viral load, or a CD4 cell count. So we started to track that data, even though, by the way, our funders, who are, Department of Public Health in Boston, never asked us to track those numbers. We started to track those numbers, and then we started to see who has the lowest and highest cell counts, who has the lowest and highest viral loads. And then we started to cross-index that information by race, ethnicity, language, income, place, etc. When we started to get not surprising, what we started to learn, when we tracked that very simple data, and by the way, we could do this, it was really primitive. Any of you could do this. Any of you can track data with an Excel spreadsheet. It's really nice to have a nice database and an IT crowd that can help you, but you can do this. It's, might not be valid, reliable, accurate, but you get some really good information. So we started to, for example, take a look at who's housed, who's not housed at higher rates. We started in relationship to their viral load. Is it high? Do they have an undetectable level or a detectable level? Sorry if I'm getting too medical for you, but that's the work that we do. Lo and behold, not surprising, we find that Black transgender folks who are transient from Springfield to Hampshire County have detectable viral loads at much higher rates than their white counterparts and heterosexual counterparts, and are evicted from housing much more often, get into trouble and have a quarry much more often, some of them designated as sex offenders much more often, making it more and more difficult to access all of the very resources that they need to access, like housing and education and health. How many of us in the health field know sex offenders, and how do we approach? I'm thinking of some of the skits that were earlier. You know, one of those should have been somebody with a big long quarry and a sex offender status, a register, and see how they're, you know, how they might be welcomed and embraced by the doctor that they go into or a hospital. A Positive Place serves a lot of historically marginalized people. We created a system whereby we made sure everybody had income, everybody has health insurance, everybody gets drug reimbursement, everybody gets connected to care. We do our best to keep people in care. It's another outcome that we actually started to track rather than just how many times did you visit somebody. We actually said we put somebody in care at this, you know, July 1st, 2014, and we're going to look in June 30th, 2015 to see if they're still housed, to see if they're still in care, to see if they fell out of care, what happened, was it a good match, whatever. So we're actually using our data in what we might call what we think is a meaningful way to support the most vulnerable populations and to do it equitably, at least as far as we have defined that.
So if I could jump in right here, because I want to give our speaker, our presenter, keynote, an opportunity to respond to all of what I'm hearing. So I'm going to jump right on you right there.
But you can't. Can I say one more thing?
No, yes, you can. But I wanted to actually point out the fact that you are sort of pulling together, from the system's perspective, all the elements our speakers are talking about. So,
Can I finish one
yes, you
point?
can.
Thank you. Okay, so A Positive Place is a system. We built all sorts of collaborations. We work, for example, with the Hilltown CDC. We have some subsidies for people who are chronically homeless and living with HIV, and they are actually administered through the Hilltown CDC and through City of Springfield, et cetera. So we created a system within a system within a system to support people equitably across the board. But what I want to say is it was a Band-Aid. In some ways, it's a Band-Aid. There's still people out there getting infected with the virus that we're not reaching. So I want to say, rather than just be a Band-Aid, what A Positive Place did was reach out to our larger parent organization, which is Cooley Dickinson Healthcare, and make sure that all of the physicians and everybody on staff at Cooley Dickinson Healthcare get involved in a number of diversity and equity initiatives to support both treatment and prevention, not just around HIV, but around all of the kinds of things that we're talking about today. So we did the system, we did another system, we're in a larger system, and Cooley Dickinson Healthcare, which is now a part of Mass General Hospital, has at its disposal the Disparity Solutions Center that is also helpful when people are sort of throwing out names of what's helpful in order to help us move this work forward. We can use the Disparity Solutions Center at our disposal and just keep growing up and up and up. And as you said, lifting up the work from this very small grassroots organization up through this major hospital system and beyond. Thank you.